Thank you so much, Tamara. It's such a pleasure to be here, and thank you for inviting me. I am a settler scholar in Corvallis, Oregon, on the traditional homelands of the Kalapuya people. I'll also say at the start of this that this is the first time I will be presenting some of these findings, so you're the first to see them. These findings are not published yet, so I ask that you wouldn't share them. And with that, we'll get started. So let's talk about the impact of sizeism on birth outcomes. So we'll start with just a little bit of background on size, and community birth. So in the United States, only about 2% of births occur outside of the hospital. So in 2020, that was about 72,000 births per year. In 2019, there was the largest recorded increase in a 1 year period. It went up by 19.5%. Most researchers think this has to do with COVID-19 and the changing risk calculus of where people give birth. Also, this increase that began in 2019 and was really visible by 2021, for the first time ever, the preponderance of those increases in births were among communities of color, especially Black women who were choosing birth outside of the hospital at higher rates. There's lots of evidence around community birth in terms of its safety. I served on the National Academies in 2020, and what we found is that when people choose to give birth outside of the hospital, there are lower rates of obstetric intervention, improved outcomes for the birthing person, very high spontaneous vaginal birth rate, and low maternal and neonatal morbidity. However, because the United States lacks integration across most of its states, most of its communities, midwifery, midwives who attend births in the community setting, so at home and in birth centers, aren't as well integrated into the healthcare delivery system as they could be. As a result of that, that's also reflected in our birth certificate. So the birth certificate in the United States varies from state to state, and only one state in the United States actually uses an intention to treat model. That's Oregon, that's my state. We've used an intention to treat model with our birth certificate since 2012, meaning that for every birth that happens in Oregon, we capture intended place of birth at the onset of labor and intended provider type at the onset of labor. Because we're the only state to do that, it's very, very difficult to use data from birth certificates to analyze outcomes by birth setting because of misclassification bias. So anyone who goes into labor planning to birth at home but then transfers to the hospital will be misclassified as a hospital birth, making it difficult to track outcomes. Because it's also such a small percentage of births that are occurring outside of the hospital, it's very difficult to do subgroup analyses. So looking at, for example, people of size, or looking even more importantly at intersectional identity and how that affects outcomes. As a result, in the US, we mostly try to use registry data. There are two really large data registries in the United States. Historically, we had Manistats data, and that's actually what this study is coming from. So that's the Midwives Alliance of North America Statistics Project and the Perinatal Data Registry. The Midwives Alliance of North America data set, I stopped working with that in 2018, and now I lead a group called the Community Birth Data Registry, and that is an alternative to Manistats that's aligned with the PDR, the Perinatal Data Registry, which is the data collection tool for birth centers, and we're then able to compare data or to combine data on the back end. So most of our studies are going to have to come from these registry systems until the US aligns its birth certificate. What we do know about the US is that the cesarean rate is quite high. It's between 32 and 33%. The primary rate of cesarean, the rate of primary cesarean was 21.9 in 2020. It's up just a little bit for 2023, which is the year that we have the most recent data for. We also know that cross-culturally and globally, we're all aiming for around 15 to 20% rate of cesarean. Over 15%. In most settings, we see very little benefit of going over that. So what this means is that cross-culturally, we're looking at how to right-size the cesarean birth rate. The goal is not to have no cesareans, but because cesareans carry their own morbidities and elevated mortality, we want cesarean births only when truly necessary. Cesarean also plays a huge role in where families decide to give birth, and a primary motivator for avoiding the hospital is a drive to avoid an unnecessary cesarean. And when we look at research that's been done in the United States over the last 2 decades, what we can see is that for individuals who go into labor planning to give birth at home or in a birth center with a midwife, cesarean rates hover right around 5 to 6%. And so obviously that's quite a bit lower than the hospital, and this is motivating individuals to avoid cesarean. I love this picture because it looks like this baby is really irritated at the fact that it was born by cesarean as well as potentially their mother was. All right. Now, when we look cross-culturally, especially in middle and high-income countries, what we can see is that there's these rising rates of obesity. And I have this in parentheses in quotes because obesity is still a really common term that's used. However, we know that people of size feel like shame and stigma are often attached to obesity. In a recent study that I worked on here at OSU, many individuals with larger body sizes said specifically that they feel like obesity is a slur. So you will hear me mostly say people of size or elevated BMI. There are places in our paper and our work, especially when we're citing past studies that still use that term, but we are moving away from that. So globally, we see a rising rate of larger body sizes, and that means that there are more and more pregnant individuals who are over or considered to be overweight or obese, so have larger body sizes when they are pregnant. And in the US, fully half of all pregnant people are labeled overweight or obese using the BMI category of greater than 25 as the cutoff. When we look at hospital-based research, what we can see is that elevated body mass index in the birthing person is a risk factor for multiple outcomes that people often want to avoid, so cesarean birth, but also other complications, including gestational diabetes. They're more at risk for induction of labor, and they're more at risk to have their infant placed in the NICU. What we were really curious about is, do these relationships between body mass index correlate with outcomes in the same way in the community setting? So the purpose of our study was to examine the association between elevated BMI, and you'll see we used two cutoffs. We did 30 and up and 35 and up, and cesarean birth. And we wanted to compare community birth, so planned home and birth center births attended by a midwife, to planned hospital births. And in our hospital birth sample, the attendant type is a mix of midwives and obstetricians. And we're going to use a model called the propensity-score model approach, and I'm going to explain to you how we did that. So we had two hypotheses as we went into it. And the first one is that we hypothesized that elevated BMI, so higher BMIs over 30 and over 35, would be associated with increased rates of cesarean birth. And we suspected that there would be higher rates in both planned community births and in planned hospital births. And that would be comparing to individuals that had lower BMIs, so BMIs below 30. We also suspected that midwifery models of care, as they unfold in the community setting, could modify the risks of cesarean birth associated with elevated BMI compared to planned hospital birth. So we set out to design a study that would enable us to evaluate that. And as I said, one of the first times I'm presenting this, and there's totally new data in here that nobody else has seen. So I'm pretty excited to show you what we found. So first trouble is figuring out where you're going to get data sets where you can compare planned community birth to planned hospital birth. So we used the Midwives Alliance of North America Statistics Project for the data coming from community birth. And then we acquired a data set from the Consortium on Safe Labor for the hospital birth sample. So let me tell you a little bit about Manastats first. So Manastats has 7 different categories of variables, over 187 variables to choose from, and they're broken down by demographics, medical and obstetric history. There's a lot on the current pregnancy, a lot on the unfolding of labor and birth, the postpartum, and the newborn. So what's really interesting about the Manistats data collection system. Well, first of all, it's voluntary. And so in the United States, any midwife who is attending birth, any provider who is attending birth is welcome to participate. In reality, what happens is that historically, CPMs are the primary users of it. About two-thirds of the births that are captured in Manistats are attended by certified professional midwives, although nurses and physicians also use it. Most of the births, about 75% of births in this sample, also come from home instead of a birth center birth, though 25% are coming from birth center births. And they're based on medical records. So what happens is when a midwife enrolls in the Manistats data collection system, they are prompted to log clients early in care before the outcome of care is known. So they're logged after the first initial prenatal visit. And then the system prompts the midwife or the midwife's assistant to continue to enter data all the way out to the postpartum visit, the last postpartum visit, which in our system is typically between 6 and 8 weeks. About 30% of community birth midwives in the United States participated in Manistats during its most active years between 2004 and 2018. And we think we're capturing somewhere between 15 and 20% of all community births based on a comparison with vital records data. For the study today, I limited the data that we were going to look at for to be between 2004 and 2009 because that was the data that I had available to me through the comparison sample. But Manistats does go out to 2018, and I'll say a little bit more maybe toward the end about the potential impact of using these older data sets. So for the Consortium for Safe Labor, this system was designed to collect data from voluntary hospital births, so from individuals who attend births in the hospital who wanted to participate. Primarily, it was used to track cesarean rates and also to look at lengths of the various phases of labor. And what you can see on this slide is that there's a lot of overlap in the variables that are collected in the CSL data set. And in fact, there were 8 categories of data where our data definitions were close enough that we knew we had comparable data in both of these groups. So it comes from electronic data that is submitted by the provider during labor. There's also information about the newborn. And their sample size, the years that they had data available for us were 2002 to 2008. So there's really good overlap temporally between these two data sets. The data collection tool for CSL is much, much larger, over 200,000 births because it is a hospital birth receiving data from 12 different hospitals. Okay, so now we're going to talk about the methods, which are really exciting. I love propensity score analysis, largely because it's not viable typically to have people who are pregnant and say, okay, we're going to assign you to the community birth group and we're going to assign you to the hospital-based group, and then we're going to see what your outcomes look like. Typically, people want to choose where they're going to give birth and who is going to attend them. So propensity score matching allows us to create matching samples after the fact, so after the births have already occurred. So we have 2 very different populations here. We have planned community birth and planned hospital birth. And we know that those samples very likely have systematic differences. For example, in the hospital-based group, we have higher percentages of individuals who have medical complexity in their pregnancy. Most, but not all of the births that are planned to occur at home are at low risk for medical complications. There's also some bias associated with who chooses community birth. Often people who choose to birth outside of the hospital are highly motivated to avoid a cesarean. They're very committed to an unmedicated birth, and they also don't match demographically with the rest of the US population that is choosing hospital birth. They tend to be, on average, to have higher education, be older, and to have a higher propensity towards being white and middle class with private pay insurance. So very different than the US population as a whole. Over the time period that we're looking at, there was a pretty substantive increase from about 93% white to only about 85% white. So more and more people of color choosing home and birth center birth and therefore being captured in Manistee, though it still doesn't align demographically with the US population at large. So when we know we have these two samples that are very different, what we want to do is start with our smallest sample size, which is going to be the community sample. And then for every birth that fits the inclusion criteria in the community sample, we're selecting one birth from the hospital sample that matches across all 8 of those categories of variables. So the only thing that should be different after propensity score matching is where the person gave birth. So the exposure we're looking at is elevated BMI, and the primary outcome we're looking at is cesarean birth. I also did in the last week here go back and also look at mortality, and you'll see why I wanted to ask that question based on what we found initially. Okay, so here we have our community birth data set. We've got 20,000 individuals to work with who meet the inclusion criteria. So we're looking at singletons that were born in the United States, their planned home or birth center births, and they couldn't have missing data on pre-gravid BMI. They also didn't transfer their care to a hospital prior to the onset of labor. So these are all people who went into labor intending to give birth at home. And then in the hospital birth, when we limit, similarly, we have another, a similar drop in the number of births we can include, so about 148,000. When we look at this group all together, when we combine them, they had a cesarean rate of 25%. So you can see that's lower than the national average. The community birth sample is bringing that down pretty dramatically. And we had about 17, almost 18% of individuals who had a BMI of 30 or up, meaning that we had, plenty of data to work with to ask our question. Okay, so in propensity score matching, you're doing this what's called one-to-one nearest neighbor propensity score matching. And what that means is that for every birth occurring in the community birth sample, we're selecting a birth in the hospital-based sample that matches across all of those variables. And the goal is to match on as many variables as possible. So these are the ones we matched on. We matched on age, race, ethnicity, married or partnered, parity, insurance payment type, and then this category is really important. There's quite a lot in this one, risk factors. So any recorded risk factors in either of those data sets, so preterm birth, history of prior cesarean, we're trying to make sure that these two samples are similar levels of risk. And again, that's because there's a higher propensity towards higher risk births in the hospital. And then we match for gestational age because we know that preterm, term, post dates are really important for outcomes. So we're able to match across multiple variables. And then in terms of the analysis, we use a logistic regression model using those propensity scores to make sure that we're matched across the dependent variable and the exposure variables that we're looking at. We also created an interaction term to look at elevated BMI by place of birth. So that would be either community, home and birth center, or hospital. And that was again, so we could evaluate that second hypothesis, which was asking, does place of birth modify the outcome? And then we decided that we would define heavier bodies as pre-gravid BMI over 30, 30 and up, or 35 and up. So we looked at them both ways. So you'll see results for both of those groups. Okay, so here's the first thing I want to show you. And this is just showing you that the matching worked as planned. Okay, so if we look we're going to take parity as the example that I put up here for you. But you can imagine that for every variable that we're matching on, we have a table like this, right? And so what we can see is that before matching, we have a lot more individuals who don't count as obese in an obese category, so normal weight individuals, and we have a lower percentage of individuals who are considered obese or have this higher body mass index. Then when you go down and look at by parity, what you can see is that it's not the same across parity. So for individuals who are having their first baby, we have a higher percentage of individuals who are normal weight, but then when you get up to individuals who have had more than one baby, you're seeing a higher percentage of individuals who have that higher body mass index. So these samples are not matched. After matching, what you can see is that the rate of individuals with a normal body weight versus those that are heavier, now they are matched. And the same is true across parity. So for every single one of the demographic or risk factor categories that we looked at, this is what you see. You see that beforehand, these are not the same samples. Afterwards, they're the same sample. In practice, what this means is that you're working with a smaller subset of the data because many of the cases don't match, right? And so that's why we move from having, over 100, over 200,000 in the CSL data down to 29,000 in each group. This is a very big propensity score study, very large sample size. Usually, once you've matched across that many variables, you get smaller and smaller sample sizes. So we have adequate power for all of the variables that we looked at. And this will be, once it's published, the largest study to use propensity score matching to look at the impact of body size and planned place of birth on cesarean birth outcomes and on mortality. Okay, so let's first look at what's going on when someone has a BMI of 30 or up. Okay, so first we have this normal body weight category and then this higher body weight category. So first let's look at the community birth sample. So for individuals of normal body weight in this sample in Manostats, we are seeing a 4.6% cesarean birth rate. When we begin to look at a comparison with individuals who have a higher body mass index, so 30 and up, the cesarean rate actually goes up quite a bit. It goes from 4.6% to 8.1%. Not quite a doubling, but a substantial increase, and it is statistically significant. The thing that is very surprising about this rate, though, is that the absolute rate of cesarean is very, very low, only 8.1% in all individuals who have a body mass index of 30 and up. And then when you look at the hospital data set, remember these are matched on all of these variables. So the difference is their planned place of birth. We see about a 30% rate for normal weight individuals. And look at that, almost 40% cesarean birth rate for individuals that have a body mass index of 30 or up. So there is also an increase between smaller bodied individuals and larger bodied individuals, but the absolute rate is substantially higher than that in the community birth setting. And both of these increases are statistically significant. Okay, now if we want to look at 35 and up, we see really similar pattern. So the community birth sample, again, under 5% for people of normal weight. And we have about a doubling for individuals who have a BMI over 35, but still the overall absolute rate is under 10%. And then if we look at the hospital, again, we have a lower rate for non-obese or smaller bodied individual, but we're up at about 45% for individuals who have a BMI of over 35. So again, this jump from about 5% to about 10% and from 34% to 45%, both of those are highly statistically significant. Okay. So as we think about whether, first of all, our first hypothesis holds true. We do see an increase in cesarean rate between normal body weight and larger body weight people, but the absolute values are much, much higher in the hospital than we anticipated. And the difference between the community birth outcomes and the hospital birth outcomes are further apart than we had anticipated. So as soon as you see that, the very first question anyone asks when they see those data is, well, are the babies at home or in birth centers dying more frequently because they're not getting enough cesareans? So of course, the very next thing we have to ask is, okay, what about mortality? Are community birth providers achieving lower cesarean birth rates for people with elevated BMIs at the expense of the infant? And we found no, that the same relationship holds, that there is a higher rate of mortality for individuals who have a larger body size compared to normal body size, both in the community setting and in the hospital setting. But on the next slide, I'll show you the actual numbers. And there is no added risk to being at home in terms of morbidity or in terms of mortality. So let's take a look at that. So the actual numbers show us that for individuals with lower BMIs, that the mortality rate, and let me say this is the perinatal mortality rate. So to have enough mortalities to be able to make a meaningful comparison, what we had to do for both the hospital and the community sample is we combined fetal, so deaths that occur during labor, early neonatal, so out to 7 days, and late neonatal, out to 28 days. So this is a combined perinatal mortality rate. So death during labor, death in the first 7 days after birth, after being born alive, and then death out to 28 days. And so what we found in the community setting, when we look at lower BMIs, the rate is 2.84 out of 1,000. It's 3.57 in the hospital. When we look at individuals with elevated BMIs, it's 1.99 out of 1,000 in the community and 3.95 in the hospital. And so importantly, we are not seeing a higher rate in community birth, which might be what we would anticipate or what some people might anticipate, seeing how low the cesarean rate is, because part of why those cesareans are done is the perception that there is fetal distress of some kind or that the baby is not going to fit, which appears not to be the case. Okay, so just a review of the findings, propensity score matching worked as planned for all of the variables we compared. We were able to get a perfectly matched sample. We found that elevated body mass index was associated with higher odds of cesarean compared to non-obese or lower body mass index individuals. So really no appreciable modification by place of birth when we're using the cutoff either of 30 or 35. Both of those subsamples saw an increase in cesarean rate when comparing the two different categories of body size. However, the absolute risk of cesarean was so much lower among individuals who went into labor planning a community birth, and there was no adjacent rise in mortality, even though those rates of cesarean were so low. Remember that for the individuals who had BMIs 35 and up, the cesarean rate was still just under 10%, which is a remarkably low cesarean rate. And when we first found these findings, I just had to sit with it for a minute because this just means hundreds and hundreds and hundreds of individuals in our country are having unnecessary cesareans, largely, we think, because of the perception that their body, because it is larger, is unable to work as well. So I want to spend a little time with you talking about the clinical implications of this study. And part of doing that, we also really wanted to know what heavier birthing people had to say about these findings. So after we found these outcomes, we recruited just initially a group of 5 individuals who we could do a deep dive in terms of case study with them, where we presented our findings to them, and we had people talk about how these findings correlated with their shared experience, and we asked them to help us interpret these findings. And so I wanted to talk to you about the things that that came up in those groups, in that group. The first one, and this is also well known in the literature, individuals in our subgroup all had experienced a longer labor duration. We also know that when we look at the literature, we find that individuals with a higher BMI tend to have a longer labor duration, and that those labor durations are often seen as abnormal and are labeled failure to progress, and then they convert to a cesarean. When we look at the data in Manastats, what we can see is, in fact, there are longer labor durations. I'm working on another paper, which you can invite me back another time to talk about, looking at labor durations, and individuals in Manastats who have larger body sizes definitely have longer labors. It's simply that the midwife is not determining that to be abnormal unless there's another indication like non-reassuring fetal heart tones, but the labor length itself is not causing midwives to label that failure to progress. The other reason, all of the 5 individuals who participated in this focus group and shared their case studies, all were told that their babies were excessively large, and all of their babies were 8 pounds or less. And so this is a common theme in the literature as well as in participant stories. They all were told that they probably had a very large baby, and many people are induced. I said early on that there's a greater risk of induction if you have a larger body size, and that is because providers are worried about the baby staying in and getting too big. Uh, this was a common theme, and I know the Birthplace Lab has done some really interesting work on this as well. And there's a lot of alignment in what these two studies have found, and that is that people who have elevated BMIs are perceived as being in poorer health. And so providers often act as though and will blatantly say, in the case of those individuals that participate in our work, that they don't think the person's in good enough shape to endure a long labor or will not be strong enough to squat and push out their baby, that they'll need assistance, especially for such a large baby, which often turns out not to be large. So the other thing is that individuals who have been asked to describe their experience as as individuals with bigger bodies have said that they do feel like fat bias and sizeism contributed to their mistreatment and that they often have very poor experiences of care. And that was certainly the case for the individuals we talked to. And I'm going to share the story of one of those individuals on the upcoming slides. This is particularly difficult because elevated BMI in pregnancy is not thought to be a modifiable exposure because in pregnancy, we don't actually encourage people to attempt to lose weight, right? We don't put people on diets. And there are very different approaches between provider types on how they address BMI. Um, so my alarm just went off to remind me that I need to tie it up in 5 minutes, and I assure you we are right on track. So I will do that now. I wanted to say that we asked people first and foremost what they like to be called, and the participants in our study said that they love the idea of being called thick and curvy. So I'm going to call them thick and curvy. So these 5 individuals that live in the Pacific Northwest who met with us as part of our pilot study talked a lot about not feeling heard, feeling out of control, and feeling shamed and blamed at every visit. And that this also made them feel like they did not want to attend their prenatal visits. It also further disrupted their relationship with food, and they talked a lot about guilt and shame for feeling hungry and for trying to satiate that hunger when they were pregnant. So this is the story of Alice. So Alice is one of the individuals who participated in the case study, and she told a story of how on her very first, so she had 2 babies that she shared with us. Both were born by cesarean after providers telling her that she'd been in labor too long. And actually, um, we might even say that she wasn't in labor yet because she was about 3 centimeters dilated both times when she had her cesareans. So she brought this to the focus group to share with us. This is when she was in the waiting room, this is something that was on the bulletin board in the waiting room, and she went over and she took a picture of it. And this, she described this as like her welcome to care. So it said risks of pregnancy worsened by maternal obesity, and it says miscarriage, difficult to visualize, problems on ultrasound, too blurry to see clearly, stillbirth, preeclampsia, gestational hypertension, gestational diabetes, abnormal fetal growth, shoulder dystocia. Head delivers, but shoulders get stuck, life and limb threatening for baby. And she said she stopped reading right there. She just like went back to her seat and wasn't gonna read about any more of it. But it also lists postpartum hemorrhage, cesarean delivery, surgical complications. And then the last one on here, it says childhood obesity, your children learn from you. She carried so much guilt and shame from that very initial visit throughout the rest. And she consented to a cesarean with the first one very quickly out of fear that any one of these things might happen to her. And in the second birth, she really, really pushed back. She declined to be induced. She went out to 42 weeks. They started her on Pitocin, even though she had a previously scarred uterus, and she never got into what was considered an active labor pattern. She was told that she wasn't able to have a functional labor pattern because she had so much body fat that her body fat was absorbing all of the hormones needed to cause labor to start, and that she had so much body fat that she would never have enough hormone in her bloodstream because it was all lipophilic, all bonded to her fat. She would never have enough hormone to actually experience strong enough labor contractions to give birth. She's just one of the five stories that were all quite similar. So if we look in the literature, what we see is that these stories are not uncommon. 69% of people who are overweight have experienced weight discrimination. Women of size report having a lower satisfaction with their prenatal experience. Uh, when you ask providers how they feel about caring for people of size, they often say that they don't like to care for people with bigger body sizes. And the three reasons they give is that they're unhealthy, they tend to be non-compliant, and they're unhygienic. And most providers say they feel unequipped to care for fat patients. Impacts of shame. We know from the research, and this was echoed in the stories of the people who shared with us, healthcare avoidance, exercise avoidance. They're embarrassed to go to the gym, embarrassed to even walk down the street. One participant said she was afraid to walk around because she didn't want her neighbors to hear her huffing and puffing on flat streets. So she didn't have hills in her neighborhood, but she would feel out of breath from walking briskly on flat ground. They avoided questioning their providers or voicing any concerns because they could tell their providers saw them as non-compliant and they didn't want to add to that. They all talked about how when your provider likes you, you get better care. If your provider decides they don't like you, you're going to get horrible care. So they all tried to be, quote, the good patient. Um, we also know that, oh gosh, this came up quite a lot, that when you have a larger body and you are reporting symptoms to your provider, the provider keeps thinking that it's your size that's causing the problem. And so they don't look for other things that might be going on. And Alice, whose picture you saw, she said that one time she went in for strep throat and her provider was talking to her about being obese. And she's like, hold on, does obesity cause strep throat? And the person was like, well, no. So it's just an example of how when you say you don't feel well, providers will jump to shaming and blaming size rather than hearing that these signs and symptoms are actually something else that needs to be addressed. And there's also just a huge amount of stress and self-loathing associated with BMI, especially as people worry they will pass that on to their clients. So what did they say they wanted? They wanted us to reflect back to them and use the language they use. So if they're thick and curvy, if they're large bodies, if they're fat, people claim all kinds of ways of describing their body and they're asking to be spoken to with the words that they use. Settle in for a longer labor. And maybe think about providing doulas to individuals. It doesn't seem to work to be like, you're only 1 centimeter dilated, go home and wait for 24 hours when they have no support at home. So settle in for a longer labor and provide support. Another thing is to adjust touch. Everyone in our study talked about how light, gentle touch feels good in labor, but the kind of massage that might feel good on a smaller body is actually quite painful when there's a lot of subcutaneous fat. So they talked about even when nurses or providers were trying to be helpful and rub their back, that often touch was painful because they didn't have an understanding of how to touch a larger body. Um, Individuals also wanted to know about potential complications, but they asked that we would tell them absolute risk instead of relative risk. They don't like being told you're at more at risk than somebody of a normal body size. Just tell me what my risk level is. And then avoid scare tactics. And I think this was maybe the hardest part of those stories is hearing some of the things that people said to each other, that providers said to their patients. And then Alice said this as the last sentence of her interview. She said, you cannot just shame someone into loving their body. And she really emphasized that shame and healing do not go together. You cannot simultaneously assert that you're caring for someone while you're also shaming them. That love and care and feeling accepted is the first step in them accepting themselves and being able to make some of the changes that they're as motivated to make, more motivated to make than you are for them to make. Okay, so this is the first study large enough to have a propensity score matching possible. The data are somewhat dated, but the cesarean rates in the US haven't changed over the time period, so we suspect that this is still relevant information. We can't control for every confounder. We only have the variables that are collected in the two data sets. We also know that representativeness in Manistats and CSL are sort of unknown because hospitals and midwives volunteer to participate. They're not required. And then a strength is this preliminary ethnographic work, which really aligns well and helps us to understand some of the findings that we have. So I think the take-home message is clear, and this is what I tell anyone who consults with me. If you are a person of size, start your labor at home if at all possible. The risk of having a cesarean is 45% if you have a BMI of 35 and over without any related reduction in perinatal mortality. Okay, so I will just thank all the wonderful institutions that support this work and open it up to questions and comments from the audience. And oh my